I was asked by Joe in June or so to see if I could put a little leadership in place and implement the clinical innovation strategy. So that is a very large job and a really tall order. And so just wanted to set, before I introduce Dr. Bahler, a little bit of context about what that means for our PCNs and what that's all about a little bit. And I think some of you have heard me so many times and thinking, oh my goodness, one more time with feeling. And so with the clinical innovation strategy, the nutshell is this is all about excellence and best practice in management of particularly patients with chronic disease. And I get asked all the time, why hypertension? What's special about hypertension? And really, hypertension is a starting point for us. When we start thinking about looking at our patients and understanding who the patients are and understanding what we need to do that's maybe different and looking at best practice and then looking at measuring that over time. If we thought of every single things that patients come and see us for in primary care, it would be overwhelming. And even thinking about hypertension and looking at measuring the blood pressures of patients and figuring out who your hypertensives are and looking at ways to improve the care, looking at how you utilize your teams, supports in your offices, it's a big job just to begin with. And so the hypertension strategy is all about that, and it's all about looking at and supporting you in your offices. We've done a lot of things, and some of you know that I've been working primary care networks for a really long time, before primary care network time, and we've done a lot of really wonderful, exciting works in primary care. A lot of it have been, at least in our networks, around the edges of the family practice, and I think this is one of the first times where we have a whole strategy that's aimed at working with physicians and their teams and the multidisciplinary teams inside family practice. That's really hard stuff, and I think one of the reasons we haven't gotten there is because there have been quite a few barriers to get there. So for the first time in my career, it feels like we have a really great opportunity for fantastic change and really great primary care. So having said all that, I met Dr. Bahler a couple of weeks ago. A few of us went on a field trip to his clinic in Sylvan Lake, and I'm really, really excited to hear his talk. I've heard little bits and pieces of it already, and we're in for a treat. I think that he has had some personal experience, and he has some very practical advice for us about how to do what we're wanting to do in our PCNs and in our practices. So I'm just a short buyer for Dr. Bahler. I asked him for some facts about him by way of introduction, and he sent me a few lines. So Dr. Bahler was raised on a farm between Sylvan Lake and Red Deer, graduated in 2002 from the University of Alberta Medical School, and then he completed his residency in rural medicine through the U of A. And in July 2004, he started practicing at his current clinic at the Sylvan Family Health Center. It provides a full spectrum family practice. And he's also the physician lead for the Wolf Creek Primary Care Network. So thanks very much in advance for your great presentation, and everybody welcoming Dr. Bahler.
Thank you. So a couple declarations. When I was driving up here to Darcy Ranch, I felt a little uneasy, and then I realized it's because the last time I was here was a long time ago when I was golfing in a provincial golf tournament, and it did not go well. So I'd also like to introduce at the back of the room Jamie, who needs to wave her hand. And Jamie is one of my RNs, and I brought Jamie with me because I thought there may be some questions around how the clinic functions from a nursing perspective, and Jamie's very well suited to answer those questions. She has worked with us twice, once before we went through a large transformation in practice, and once after she saw the light and came back from Alberta Health Services. So she is in a unique position to kind of see before and after, and I think she can answer questions around kind of how staff functions. The one thing we wanted to know is kind of the complement of the room, and so I was just wondering, how many physicians are there in the room? And then how many nurses, MOAs, LPNs? And then I gather there's some clinic facilitators and that type of thing as well, or PCN employees? Okay, perfect. So The goals of my presentation today are pretty simple. I want to discuss some key ideas around practice transformation. I am going to use hypertension as a theme because that is one of the themes of your primary care network. We're going to use that as an example, some things that I've done and some rationale for how to approach transforming your clinical practice. And I hope everybody can leave enthusiastic about starting down a new path and doing things in a more comprehensive way for our patients. So this is where I live, Sylvan Lake. Although the lighthouse is scheduled to be demolished, which is, yeah, exactly, which is a bit sad for a guy who grew up in town. Sylvan Lake has a population of around 12,000 people. We serve several communities right beside Sylvan, so our catchment area is around 18,000. And we have a huge summer tourism population, so we get about 1.4 million day visitors to Sylvan Lake kind of in a summer. And so we do deal with a huge influx of work around the summer months, and we've had to have some strategies to try and deal with that problem. This is my practice style. I try as much to be the full spectrum family doc that we were talking about. I don't know if I'd hack a leg with osteomyelitis, but I might try and sort some of it out. I do obstetrics, I do family medicine, I do hospital medicine in Red Deer. We provide services for 4 different long-term care facilities. I'm the medical examiner for my region. I do a rotation in the unattached service in Red Deer, a service, by the way, that exists only because family docs aren't doing hospital work as much as they used to. I'm the physician lead for the Wolf Creek PCN, and I'm the site coordinator for resident and student learning in Sylvan Lake. And my personal verified panel is 1,917 patients. So this is my panel size. This is yesterday's number. My panel is kept up to date weekly. And so when I talk about service provision, these are the people that I'm trying to provide service for. So my journey begins. Now, I don't know, there are obviously some people who know who Journey is. And this is relevant because I actually, some friends and I dressed up as Journey for Halloween. And with Halloween coming up, I thought, that kind of be neat to bring Journey up. So it's not exactly that kind of journey, but when I started, I joined a very well-established clinic. 2 physicians had close to 50 years experience in the community. There were 5 of us at that time, and one physician was paid in chickens at one time. And, he told me stories about patients being unable to pay for services before the schedule of medical benefits and negotiating with patients on price for services. So, very well-established clinic, a very well-seasoned team, very ingrained into the way things had always been done. And after surviving the first couple of years of practice, which I think all new grads do, I started to say, what am I doing? Is this right? Is there a better way to do things? These are the things I thought I know, and I was born out of a system. This is what I was taught in training, the one problem, one appointment theory, that you had to control staff costs as a family doctor, or you would go broke. At the time, we had a model where we tried to keep to a 1-to-1 or a 1.2-to-1 staff to doctor ratio. So we really ran a very skeleton kind of crew of staff in the office. And having trained staff doing clinical work is for ARPs and universities. I've heard that several times across the province, but it fiscally can't work in primary practice. And it's normal not to have time or energy to do preventative care and robust chronic disease management. And in that system, I saw a number of things. One is the office staff are frustrated. There's a lot of rework. There's a lot of running around. There's a lot of very frustrated patients. There's a lot of frustration in clinicians just running the rabbit wheel trying to keep up. And there's a very low priority on preventative care and active chronic disease management. And most of our day was going from spot to spot, whether it be hospital, long-term care facility, office, just putting out fires. And, a lot of the days really felt like this. So I want to talk about change, because I entered a model that really had not changed in decades. The way the office was organized, the way patients came in, the way they were seen was the same for 20 to 30 years. The payment model changed, level of complexity changed, but the system really didn't have any significant change. So if you think about it, I want everybody to think about industry, sport, whatever you want to think about. And I want you to try and find an example of one thing that has been successful for 30 years where there's been no change in the way it was made, the way it was marketed, the way it was tested, the way it was used. I've had some people come up with a couple examples that were close, but there really aren't any. Okay? You have to change as times change, as expectations change, or you get left behind. So in my change examples, I have Craig McTavish, the last guy to not wear a helmet in the NHL. Entertainment changes. The way we consume media and entertainment has changed drastically, especially in the last 10 years. And drive-in movie theaters, for the most part, are a thing of the past, although there's one here or there you can still find. Hair changes. You still see the odd guy with a mullet walking around, but it's certainly not the norm anymore. Technology changes. This is a picture of the first computer, okay? So this computer had 19,000 resistance tubes, and when it went down, you actually had to check every one to figure out which one it was. And turns out our demographics change. And this is a slide that shows Canadian demographics over time. And that giant blue bump is the baby boomers, okay? And so as that bump moves up over time, what you're going to see is in the next 20 years, we're going to have a massive amount of 65 to 80-year-old people, okay? And this is going to stress our system to the max in the areas of chronic disease management, in the areas of home care, and in the areas of acute care. My town changes too. So, you know, in 1980, it was 3,700 people, and now, 2010, it's 11,000. We went through the oil boom phase, 2001 to 2006. The population went up by 37% in 5 years, totally outstripped all the resources and infrastructure. So demographics change, towns change, things change, and we weren't changing. And change is coming, whether we like it or not. I think the real first reform that's going to stick is primary care networks and the work they've done. And that's not to say that primary care networks have been universally successful across the province, because that's not true. You know, there are some primary care networks where they've had a lot of struggles. There's a lot have been reformed a number of times. But in there are pockets of people that have done really great things that are starting to change our system. Multidisciplinary teams are going to be the way of the future. There is no way around it. Family care clinics are coming. You know, I met with the Minister of Health this week. They are coming, and they are going to change things. It remains to see if that's going to be good or that's going to be not good, but they are coming. We have prescribing pharmacists, extended spectrum pharmacists, we have nurse practitioners. Things are changing. And the problem with change is that often as docs we're a little bit impatient. You know, sometimes when we see something we like, we want to do it like that. We want everything to change. We want to cover all patient needs instantaneously, and we want to throw the system up on its head. So there are advantages of collaboration, and what I want to stress here is that working in a multidisciplinary team is not replacing the doctor, okay? I truly believe the doctor-patient relationship is at the core of caring for patients. And the teams we build around them are to enhance the doctor-patient relationship, to create more time for us to do the things that we're good at and spend more time with patients when it's appropriate. You can achieve a lot more with a team. You can be much better coordinated. The team can share the responsibility for the clinical load. Clinical care can be measured as a team and shared, and you can share the responsibility of doing that. And in a truly high-functioning team, processes continue to evolve and change. And there's also more faces, more personalities, more perspectives that you can bring to your patient that can help motivate change and care for patients. So it would be really good if you guys could have a quick look at this, and these are just a list of things. So the two most important factors in completing clinical tasks, and this is based off some primary care research that was done in the United States by Barbara Starfield, who's kind of one of the forerunners of primary care in North America. And so obviously I'm talking about teams, so teams are one of those things on the list, okay? And the other obvious one is practice size. So if you have 5,000 patients, it's a lot more difficult to complete clinical tasks than if you have 500 patients. That's not saying it can't be done, but you have to design a very different team to look after 5,000 elderly patients than 500 young patients. And that's where understanding who we're looking after is really, really important. So everybody would like if we could go from this to this just instantaneously, and unfortunately that's not the case. You know, that's fun, but it doesn't really work, okay? So the example I want to use is management of hypertension. So I want us to think about a clinic strategy for population management of hypertension. You guys have done a lot of work in hypertension. So having done a lot of work, I'm wondering if around the room I can hear from the groups, what things do you need in your clinic to manage hypertension, from diagnosis to treatment and maintenance? What tasks do you have to be able to achieve in your clinic? Right. So take your blood pressure. So you have to know how to take a blood pressure properly, right? Anything else? So you have to improve processes. So you have to screen people, right? So how are you going to achieve screening in your population? So that's one thing. Anything else? Track it, right. So, you know, in my world, in my clinic, that's problem lists. So identification of problem list. How are you going to track it? How are you going to create that problem list so you can follow those people? Anything else? Have to have the patient show up. So patient buy-in is a big thing. So they have to have the patient show up, or you have to have a strategy to find the patients that don't show up that you're looking after. Sure. So that's that partnership, right? That's the core doctor-patient relationship. You know, how do we get buy-in from our patients to take some responsibility for their own care? You know, what strategies do we have in place to get them to show up for screening, or get them to show up for maintenance, or stay on their blood pressure agents, or understand why it's important that we actually manage blood pressure? Sure. So what does your team do for you? Why do we want a team to look after blood pressure? What do they help us with? So lifestyle management, so education, you have to have a strategy to talk about lifestyle management. Somebody has to put them on medication, so I hope the docs think that's important too, because, you know, that is a very important piece. So the point I'm getting at is it is very complicated, okay? And so if we brainstorm around hypertension, screening. So who are we going to screen? What age are we going to screen? How often are we going to screen them? How do we make the diagnosis? Who does the work to make the diagnosis? At diagnosis, what diagnostics do we have to do? What physical exam do we have to do? What teaching has to be done? How do we enter that into our EMR system? How do we track those patients? How do we follow those patients? How do we pull a report on those patients or search them if we're looking for a bigger data set? But there's more, right? Who prescribes treatment? How often are you going to follow it? What's the strategy to follow patients? Who does patient education? Who discusses lifestyle intervention? Do we do that in an individual setting? Do we do it in a group setting? Do you recall patients, or do you let them come in on their own? If you're going to recall them, how are you going to do that in your clinic? And how do you find those people that never come in? So my practice has a massive population of 50 to 70-year-old agriculture oil field workers that are male and never come to the doctor. Never come to the doctor unless they're bleeding or they're having chest pain or something's really wrong. So the point is, how do I go find those people that I've accepted responsibility for and try and identify the people with hypertension and keep them from having their heart attack? So this covers one bullet point in those 8 bullet points, okay? So this is from the CHEP guidelines. This is from 2011. There are 2012 guidelines out there. So this is purely how you measure and diagnose hypertension in the clinic. So that encompasses one of those 8 bullet points. In, you know, the Norman Rockwell days of coming in and putting the blood pressure cuff on and saying, oh, your blood pressure is high, here's a prescription. You know, one of my partners says when he started medicine, there was 2 drugs for hypertension. That was all the choices they had. You know, it's pretty easy, you just pick one. So we've gone from coming in for one visit, putting on a blood pressure cuff, diagnosing blood pressure, having one pill to choose from, really not having any lab tests to kind of do, really not knowing kind of how to monitor these people on an ongoing basis and sending them on their way to a very complex system to actually even make the diagnosis. So it's not one visit, it's 3, or it's 5, or it's home readings, or it's ambulatory blood pressure monitoring, where the criteria for all those different ways of doing things. The point is that it's complicated. This is not easy work. Medicine is a complicated system. There are complicated expectations, and you have to start somewhere. And as docs, we have to allow the system to kind of organically evolve, but we have to be involved in that change. We have to be advocates for our patient. We have to help redesign our systems to care for them. And to do that, you have to know who you're actually looking after. And I'm very surprised, I don't know if I'm surprised anymore, but I can tell you across the province, there are very few clinics who actually know who they're responsible for. So, is there any clinic here that has a verified panel list that they know for sure they can print off and say, these are my people? Good, excellent, excellent. Now, how did you do that?
We started by printing off everybody who we felt was our patients. As they came in, then we asked them, and we phoned people, and then we just keep it up.
Excellent, excellent. So you have to have a strategy to initially identify that panel, and then you have to have a strategy on an ongoing basis to make sure it's accurate, because people move and don't tell you, and people die and get left on the list. And there's nothing more embarrassing than my nurse calling a patient, or a house asking them to come in for screening, and them going, well, they died 2 months ago. That's a bit awkward. So having an accurate panel is very important. There are a lot of ways to do that. There's the Alberta Health Way. That's basically how PCNs get funded, is using the 4-cut method from Alberta Health and Wellness. The problem is we know this is notoriously inaccurate. It's incredibly inaccurate. In my setting, there's about 30% discordance between what our actual panel was and what Alberta Health told us. There's the Health Quality Council of Alberta, which is going to hang its shingle soon, and they are probably going to have the most robust set of patient demographics and data points that they will actually be able to pull for clinics. They're not doing this yet, but it is coming soon. And I think the most accurate way is that personal list, that personal verified list. That's the relationship where you've agreed to look after a patient has agreed that you're their doctor and want to look after them. So we're going to talk a little bit about how my staff evolved, okay? Our goals were basically service delivery and clinical care. We decided we were going to go with an entirely team-based concept. This was after several years of failures with doctors trying to be in charge of how things were managed in the clinic and changed. Our staff ratios were, as we talked about, 1-to-1 or 1.2-to-1 in 07-08, and they're now 3+to-1 on a daily basis in the clinic, including 3 RNs doing mostly clinical work, although Jamie tells me she still does too much administration on the way up, so we're working on that. We have regular team meetings, and we actually have an efficiency and improvement person at the clinic. That is her job, is to look at data measurement, efficiency, and improvement. Each MD has a MOA that works in a 1-to-1 relationship. So when I'm in the clinic, I have my own MOA. She knows how I work. She knows how I prepare things. She synchronizes the room, the equipment, the patient, gets everything ready for me. She does just-in-time screening and prevention on each patient at contact. So right now, if you're a rig worker and you come into my clinic and you have not been there for 2 years, before I ever see that person, they will have had their blood pressure taken, they will have been offered colon cancer screening, they will have their BMI done, they'll have hopefully their problem list updated, and they will leave the clinic with all appropriate screening maneuvers done. They'll be screened for tobacco, offered smoking tobacco cessation. I'm cued in to talk to them about it if they're keen on doing it. So they get their needs looked after, but we also capture the stuff that they don't do because they're not a frequent presenter to the clinic. When I'm not there, like today, she's back at home combing over my panel. So she's looking for patients that haven't been in 2+ years. She is looking at outstanding screening reminders, bone mineral density, mammography, hypertension, Pap screening. Sometimes it's more appropriate when people haven't been in to actually bring them in for a physical and do it all in one pot. Sometimes they've been in and stuff just hasn't got done, and all they need to do is do their mammogram, and so she provides them with the requisition to do that. Then I have my RNs. They're kind of a supervisory level above the MOAs, and they basically provide supervision, assistance, and support for the MOAs on a daily basis and on a planning basis. They function as my proactive office encounter technicians, and that's a fancy term, and I don't know where it's coined from. But basically, if you come in to see me for a physical, all the appropriate screening and investigation will have been done beforehand. So when you come in, if you're an elderly person coming in for a driver's medical, you've had your MMSE, you've had your kind of preliminary driving assessment, you've had all your lab work done, you've had all your screening done, and basically I come in and I do the driver's medical with all information at hand. This saves me a lot of work and it saves me a lot of visits. They also do prenatal management, so they do all the 12-week prenatals other than the physical exam portion. They coordinate registries for prenatal patients, they do all the investigations for prenatal patients, and they liaise with the hospital in terms of management. They're responsible for all policy and procedures in terms of MOA work and nurses. They're community liaisons as well. They attend family conferences for patients in long-term care. Jamie kind of functions as a point person for one of the medical specialty clinics that are particularly problematic for me, the heart function clinic in Red Deer. And they manage all the chronic disease care plans for patient, which means they enter reminders in, they do the yearly reviews, they update all the problem lists, the medication list. They basically create the document that allows me to go in and focus on what the important parts are for the patient and what we need to really target over the next year. I have Barb, who's also an RN. She is the chronic disease person in the clinic. She does diabetes management and education. She does a quit core smoking cessation program, both a group program as well as individual counseling. She runs our WeightWise group, our walking group. She does COPD, asthma education and action plans, and she does one-on-one lifestyle counseling and education. I have Lynn, who's my data collection and management person. She's in charge of office efficiency. She coordinates all the learners at my clinic because they were getting tired of people showing up and saying, Dr. Bahler, you didn't tell me this person was coming. Okay. And she supports team functioning by working with my clinic manager to coordinate information in the clinic and keep everyone on the same page. Chris is our new clinic manager. This is what he's going to be doing. He's just started in the last 3 weeks, so we've gone under a big transition here. He basically is day-to-day operations. He going to be working to achieve our goals with the team. He has background knowledge of process improvement. He's an IT specialist. He has lots of experience in human resources. And basically, he's the person that's going to help facilitate the team process. And we also have a dietitian that comes in, a podiatrist that comes in. We have good community relationships with pharmacists that can help us out. And we are starting to really work hard with integration between us and Alberta Health Services. So things like partnering with home care. We've actually been able to get buy-in for Alberta Health to realign the way home care was delivered in our town so that it's actually based on panel. So I have a home care worker who looks after a panel of my patients. Another clinic in town has a home care worker that looks after a panel of their patients, trying to build connection that kind of enhances care. So these are some keys from my experience and my research and my work in primary care across the province. Start slow and layer on your success. Don't go for the rapid model change. Start slow, build something, tweak it, make sure you're happy with it, layer the next thing on top. The one thing you'll find is that it does organically evolve, and one thing leads to another. So you'll be doing hypertension and working on your protocols for hypertension, and something else will come up. Like when you get to the point of, well, how do we recall patients, or how do we do screening for people that don't present, you're going to realize quickly you actually have to identify a panel to be able to do that. And when you're doing hypertension screening, you're going to find out that a lot of hypertensives may also have diabetes. And you may say, well, let's look at diabetes management. How do we track those patients? How do we bring them in? How do we make sure their screening maneuvers are done? There's no right way to do this. I honestly believe there's no wrong way or right way to do this. I think it's a very personal approach, and you have to do what's going to work for your patients in your setting, because patients in inner city Edmonton obviously require quite a different care approach than people in rural Alberta. And so when your clinics are evolving and you're working with your PCN, think about how this is going to best work with your setting and work with them to tweak your protocols and tweak your approaches so that you can actually get something that works. And once you have a little bit of success with one thing, it usually translates into motivation to work on something else. And that, I think, is the best approach that I've seen. And the most successful teams I've seen in the province utilize this approach. The other thing is remembering that patient value is key. You know, whether you're working on something as a doc, as an MOA, as a nurse, as a pharmacist, go back to the principles of what is best for our patients, what is going to enhance our patient-doctor relationship or patient-team relationship. You absolutely have to meet as a team. If you're going to bring people into the clinic, you're going to support the clinic functioning, you're going to create a team, you have to be meeting and knowing what's going on. You can't just expect to throw people in and make it work, because it just doesn't happen. And everybody has to know what their responsibilities are. This is very important. You can't start a team without knowing who's doing what and who's responsible for what. You have to have a reliable way of communicating, and you have to measure what your team is doing. And if you're putting a lot of money and you're putting a lot of time and you're putting a lot of effort into hypertension screening, you really want to know that you're actually doing a better job doing hypertension screening. So this is examples of wins from my clinical setting. So our occult blood screening, colon cancer screening rates went from 45-ish% to 90%, and that's just at contact. Hypertension screening went from 60% to 90%. Our goal is 95% of the entire panel now, not just people presenting at contact. We had drastic improvements in offering of smoking cessation services and capturing people smoking tobacco. And we have a very proactive approach to prevention and screening now, as well as chronic disease management. So trying to move resources out of putting out fires to preventing fires from happening in the first place. So this is what we do for hypertension. And I'm going to say that again, this is not a solution for everyone. I don't think you can kind of cookie cutter this and drop it in somewhere else and have it work. But this is kind of what our team decided on over lots of discussion and a bunch of trial and error and study. So the MOA nursing staff screen all patients over 14 yearly for hypertension. Initially this was done manually. They had to go in and check and see if they've been screened. Now it's done using an EMR pop-up reminder. And basically, if you come in for any reason, you'll get screened for hypertension if that pop-up comes up. It's done at any point of care with the patient. If you actually have a diagnosis of hypertension, there's a protocol that increases checks every 3 months when you present to the clinic. So if you haven't been there in 6 months and you have hypertension, your blood pressure will actually be checked. That's the initial thing, that's the screening. Now it's how do you make the diagnosis? That initial screen is high, and what do you do with that? Well, unfortunately, a lot of people's initial screens are high, and I don't know that that really means too much. So they actually have leeway then to put them on a BP True monitor, and we chose to do automatic monitoring over repeated physical monitoring because it saves time. So they put them on the monitor, they can go set up another patient for me, and then come back and look at the results. So once those results come in, if the person is in fact high in terms of screening, that's handed off to either the patient to follow up or the nurses to follow up. It's not me. And so this is a bargaining process. This is an agreement with the patient that they're going to choose to do home monitoring. Maybe you can provide them with a lent-out blood pressure monitor. Maybe they're going to do it at the pharmacy. Maybe they already have a blood pressure monitor. Or they're going to agree to come back and they're going to book in to see my nurse, and they're going to do the repeated screening until they meet the criteria for actually diagnosing hypertension. So this is, some of the choices, and this is again from the C.C.F.P guidelines in making a diagnosis of hypertension. Once a diagnosis is made, the nurse then has a protocol to order kind of the investigations that one would generally do for a hypertensive patient looking for end organ disease or comorbid illness, so glucose, lipids, ECGs, creatinine, electrolytes, that type of thing. They also enter it into a very specific field in the EMR, or the physician does, so that you can actually track that patient population in terms of looking for them down the road. This allows searching, this allows creation of reports on how many hypertensives you have, when have they last been in, who hasn't been in. So patients come to me packaged with a diagnosis, all the investigations done as per the C.C.F.P guidelines, the screening labs in place, their problem entered into the computer, the reminders all set up, and then I get to focus on what I think the physician role is, which is education, prescribing treatment, and agreeing on a follow-up plan with patients. And this follow-up plan is going to be different person to person. And this is where your individualized expertise and that clinical acumen comes into play, and working with the patient to find common ground. We can then initiate a chronic care plan if they have a bunch of other comorbidities that are a little more complicated and we need to follow them more closely. We can enter staff recalls in, so if they decide, I'm terrible at monitoring, I'm never going to come in, please put a reminder in and call me. We put that in and they'll be called, the nurse will check their blood pressure. They also have education options past what I tell them about. There are group lifestyle programs in town, or they can choose to sit down with Barb and do a one-on-one lifestyle counseling. Patients are followed then presenting to the clinic every 3 months if they have a diagnosis of hypertension. And then the last thing is my MOAs will go looking for those people who have not been screened or who have a diagnosis of hypertension and are not being followed. So Kim plays Where's Waldo a lot. And unfortunately, because of the nature of a lot of the people I see in the work they do, they're often working in Fort McMurray, they're working in Grand Prairie, they're working over the province in the oil and gas industry, and sometimes finding them can be a lot more difficult than you might assume. So people change phone numbers and people move and they never tell clinics that. And this is a challenging process for the MOAs, and this is a process that they're still learning how to do really efficiently. And so we're just really working into the nuances of what the best way to do that is, when do we do it, how often do we do it, how do patients call back, how do we get a hold of them. So this is what I get asked a lot. Because obviously working a team costs more than working by yourself in terms of staff. I work fee-for-service. I am handicapped by the same system that the vast majority of family docs in this province are. I could give you a talk on why fee-for-service is awful, but that's another hour talk. I do have some support from the PCN, which is, I think, some of the model you guys are rolling towards. So Barb is actually funded by a PCN. The dietitian is a PCN employee. I actually recoup some of the costs for my RNs from the PCN as well. We've really shifted our PCN focus to the periphery, as Joe was talking about, which when we actually looked at outcomes wasn't overly effective, to working right in the primary care environment. So essentially all our PCN work is done in the primary care environment right now. All the staff, we don't have a freestanding building, they don't have separate clinics, they work side by side. If you walked into my clinic, you would have no idea who was a PCN employee, who was a clinic employee, who was a mesh of both. We also moved and over doubled our clinic space in 2008. This was kind of a 10-year plan that turned into a 2-year plan. And I was telling Jamie on the way up, we now have 52 computer stations in our clinic, and they're for the most part totally full with staff and people working. And so there's space considerations when you do this work as well. Who do you pay for? Who pays for the space? How do you create space to work with these people and make it financially viable? So I can tell you for sure that my net revenue is more, and my cost of doing business is less now than it was in a one-on-one environment. In fact, research in primary care across not just our country, but actually the world, actually supports this. So if you do not have adequate staff to do your work, you actually create overcosts, and you make less net revenue. There's a debate out about what the right number of people is to achieve the sweet spot where you're not paying for too much, but you have enough services. And I don't think anybody can answer that debate because it's going to be very individual on the basis of the patients, on the basis of the clinic. The reason that this is the case is I see more patients more efficiently than I ever did before, because my team supports me. So those diabetic visits where I was spending 20 minutes on education, making sure the correct technique for injection of insulin was done, making sure investigations were complete, talking to them about their blood sugars, talking to them about insulin adjustment, making follow-up plans, entering reminders in, that's all administered by my staff. And what I'm doing is talking to the patient about what's important to him, how's your quality of life, how's it going, are you okay with this plan, do we need to change anything, how can we support you being actively involved in the management of your care. And I can get more done in half the time because I'm not worrying about the administrative part of looking after chronic disease management. I do a way better job at screening. I do a way better job at prevention. Chronic care plans do actually generate revenue, okay? And I run a business, and we use chronic disease plans to manage patients' care, but they do somewhat offset the costs of having a team to do that, okay? And we have a rule of recapturing costs, which means if you can present me with something that you think will increase my efficiency and recapture the costs of the staff to do it, we will take a leap of faith and do it. And we have to stop thinking, about revenue and cost and think more about net revenue and what we bring home, okay? And docs are notoriously bad business people, and I hate to say it, across the province, we do not run businesses really well. Again, there's actually a lot of research on that too, that docs do not make really good business managers. But if you do the math, in my clinic, which will have 5 docs running at maximum any time, 4 to 5 on average, if you can create a position that will get each doc to see 2 people extra a day by fee-for-service, you have actually made enough money to hire 2 MOAs, an LPN and an MOA, 1 RN, whatever the case may be. You actually don't have to create that much more efficiency to actually pay for the extra staff. And so if you can make the argument that this position will make us more efficient and we're going to generate more revenue, and it's going to pay for itself, and it's going to better patient care, I can't see why you wouldn't do it. But the key is to really focus on what they're going to do for you. Don't hire people without a plan in place. And you go for the low-hanging fruit in terms of efficiency and what they do. Diabetes is an obvious one to start with. Screening is an obvious one to start with because they take a lot of docs' time, and it's a lot of administrative work that doesn't need to be done by docs. So you try and get everybody in your team operating to their full scope of practice and doing the maximum stuff that they can do within their competency level, and you get them away from doing stuff they don't have to do. And that is the key part of designing a clinic system. So if we talk about the future, I think we talked a little bit about this in terms of primary care reform. There are things on the horizon in terms of primary care, the FCC's coming in, the uncertainty about contracts, a little bit of uncertainty around PCNs and how this is all going to mesh together. Doing primary care reform takes change, it takes commitment, sorry. And it was said in the last presentation, there's been a lot of pilot projects over the years. There have been a lot of things done that have not translated, into actual practice uniformly across the province. And the problem is that a lot of those initiatives didn't have buy-in from the primary care system as a whole. And I really believe primary care clinics are at the core of offering primary care services. If you don't include them in the planning process, if you don't have buy-in in terms of what's important to patients, what docs think are important to patients, what patients think are important to themselves, you're never going to have any lasting change. And I think team-based care is the future of healthcare. I don't think there's any denying this. Looking at the demographics over time, you're not going to be able to manage patient care without a team. Practice quality improvement and chronic disease management are buzzwords. They're buzzwords in political circles. They're buzzwords in Alberta Health. They're actually buzzwords in new graduates as well. Okay, if you're a new graduate coming out to work, having done a ton of medical education in my kind of 9-10 years in practice, they don't want to work the old way. They don't want to be the single doc, unsupported, in a clinic without a team. They want to work in a high-functioning team environment. There's going to be continued changes in healthcare that are expected by patients and expected by government. And data collection, access, practice quality improvement are going to be expectations at some point in time. Our system cannot continue down the path that it's continuing down. If you look at quality of care versus costs in Canada, it is totally running away. Alberta is actually running away further than the rest of the province. And we are getting to the point where we're actually catching up to the US in terms of money we spend but get nothing back for. And this is not going to be accepted by the government this is not going to be accepted by patients. And there are some big changes coming in the way we do business. And we cannot stand still and watch this happen, because if you're not proactive, it's going to happen to you, and you're not going to have a say in what happens. So don't stop believing. In the words of Journey, you can create a system that works. You can better patient care. You can do that without emptying your pocketbook. And the biggest thing that I think I've seen in our clinic is a culture change. You know, docs are happy. My clinic staff is excited about working. They're excited about change. They're excited about process improvement. We have huge buy-in from staff in terms of suggestions for improvement, for buy-in in terms of monitoring patients. My staff works really hard, and we actually have a very stable group of staff. And Dr. Paulgard, who was out to see me, was talking about staff retention and how problematic staff retention can be. And it's no different where I work than here. I can't compete with oil companies in terms of paying secretaries, in terms of paying, you know, nurses, in terms of paying people like that. But what I can do is I can provide them with a better place to work, where they're happy and they're involved and they're making a difference in patient care. And I really believe that that will keep people around. Money is actually a fairly poor motivator. It's a poor motivator for docs as well, and it's been a poor motivator in terms of society. And again, there's tons of psychological research that show how poorly money motivates us to change. As physicians, as nurses, most of us got into this field because we like it. We thought it was exciting. It was a chance to help people. It was a chance to be more than a job, as was said in the last presentation. And I think if you can get that feeling in your clinic that you're coming to more than a job, you'll have good luck with keeping staff.